Melissa Brimelow. So Melissa joined Children's Health Queensland in 2016 to further clinical paediatric training. She's a long-standing interest in stability of medications. Her current role as a pharmacist with CHQ at home involves direct care of paediatric patients requiring intravenous therapies at home. She's implemented many processes within the CHQ at home multidisciplinary team to promote quality use of medications, service expansion and process management. She gained experience in medication stability during her honours degree at UQ and researched the stability of extemporaneously compounded medications manufactured by Queensland Health Central Pharmacy. Thanks, Melissa.
Thanks, James. It's a bit of a change of tact with my presentation, a bit more of anecdotes from the front line as paediatric HITH practitioners, but it's been lovely to listen to Gabby, Dave and Fiona's innovations in the HITH space as well this evening. So I'll be also discussing some of the considerations that are required when delivering an OPAT or HITH model for the care of a child. I just wanted to mention moving forward in this presentation, I'll refer to OPAT HITH more generally under the umbrella term of in-home care. Now, my presentation is probably a bit more broadly focused on paediatrics, so apologies in advance for those expecting an oncology-centric presentation, but the principles are definitely the same when considering care. Now, I just wanted to extend a special thanks to Molly Blair and Claire Isles for some of their content advice and some of their quirky little anecdotes that I'll share this evening. I also just wanted to start by asking you to just take a moment to reflect on your answer to this question. What does home mean to you? For me, the answer is security, comfort, privacy, and belonging. So now imagine you're a 3-year-old and about to receive daily visits at home from a health practitioner for the administration of IV antibiotics. How might you feel? How would you like them to behave? I guess the unfortunate reality, particularly for oncology patients, is that unpleasant medical interventions are an inevitable component to their treatment journey. So a challenge for in-home care is to make sure that these experiences don't creep into the home environment. As in-home practitioners, every day we are given a rather privileged opportunity to administer care in this very unique setting that is home. I would argue that the practitioner-patient power dynamic generally would shift in favour of a patient when they're in their home compared to the inpatient setting. So for the in-home services to function successfully, that practitioner-patient relationship must foster respect, autonomy, validation of needs and values. So modern healthcare is imbued with a lot of patient-centric rhetoric. How do in-home services actually exemplify this? Well, I think this is best summarised by a feedback statement we got from one of the VIPs at CHQ at home. And I quote that the in-home team always asks me where and when I would like my dressings changed and wait for me to invite them into my room. It makes me feel like I have control and that I'm being cared for. I wasn't just another patient, but a person. So I guess for children who might have phobias or anxiety, planning interventions such as dressing changes on the same day as in-hospital clinic reviews is a strategy that we often employ to remove some of that fear in the home environment. The inclusion of an OT has also helped to achieve more positive treatment outcomes. It is also worth considering deferring unpleasant interventions in the home, such as the administration of intramuscular injections where clinically appropriate. A little while ago now, in 2009, the Department of Health commissioned an industry scoping study into paediatric medicines. Again, a quote from the executive summary. When it comes to medicines, children are at significant disadvantage to adults in every country in the world, including Australia. Adults benefit from a well-evolved system of testing and trialling medicines for safety, formulation, dosing, and efficacy before they are registered for use. And unfortunately, in paediatric in-home services, we too aren't exempt from some of these challenges when it comes to therapeutic options. Many of the stability studies in the in-home arena have been designed with a focus purely on adult-centric doses. So this, in particular for antimicrobials, has resulted in quite a limited range of concentrations in which we can compound the very broad weight-based dosing regimens that we often see in paediatric patients. It's no, I guess for in-home services, the use of elastomeric infuser devices are also quite a bread and butter modality by which we administer medications. And unfortunately, due to some of the limitations around the specifications, many of the devices on the market are limited to quite narrow fill volumes. So this, in addition to an already limited concentration range for paediatrics, often precludes the use of some of these devices for some of the smallest of our paediatric population. But I guess it isn't all doom and gloom. There's definitely been a lot more recent collaborative approaches to clinical trials in general, and we've seen a lot of impressive advancements in the fields of paediatric oncology, CF, HIV and immunisations, just to name a few. So for in-home paediatric services, that collaboration with industry and the broader national in-home sphere will no doubt address some of our current limitations being experienced. So I want to share one of the stories from the team here about a young patient who once came onto our HITH service. As is routine, a nurse visited the patient and their family in the morning for the administration of IV antibiotics. During the consult, the patient excitedly mentioned that they were going to a party at the Chandler pool later that day. The nurse, being the bearer of bad news, advised the patient and their parents that it might be best to stay home today and see their friend another time because their PICC line and infusion pump just must not get wet. Now, I refer your attention to the picture on screen. This is an actual image of the Chandler Aquatic Centre in Brisbane. So you can see the temptation there for a young child. So cue a phone call to the on-call nurse later that afternoon from the patient's mother. Hi, very sorry, but my child's infusion pump is no longer working and their dressing is very wet. Sorry, but they've decided to just take themselves down the water slide at the Chandler pool. Children will be children, as the saying goes. So age-appropriate conversations with patients, in addition to their parents and carers around the service provision, treatment expectations, and the impact of interventions to their activities of daily life is a very important component to discuss before even starting a in-home therapy referral. It's not uncommon for families to also request treatments at school or daycare for their child. After all, the big selling point of in-home care is a return to normal life. However, these environments may not always be the most appropriate, and consideration about the choice of IV access device, infection risk, sand and water play in these environments also need to be considered, and some of these limitations discussed with the patient and family at the time of referral. Engaging with some of these education organisations has also presented some challenges. Many of these organisations will require additional information and permissions from in-home services so that they can facilitate on-site medical treatment. This can add quite a significant amount of workload for some services. Opportunities to engage consumers and carers in early discussions around service planning and delivery should be explored wherever feasible to try and enhance efficiencies. Another story, this one from me, a 5-year-old patient who was referred to the HITH service for the IV antibiotics was admitted to hospital on day 1 for commencement of their treatment, as well as a PICC insertion under GA, with a view to transfer to HITH on day 2 to finish their 2-week course. The patient recovered very well from the GA and the green light was given for transfer home. Again, proceeded to the ward with medication supplies and a very generic blue bum bag in tow. On approach, a delightful and chatty 5-year-old girl greeted me. I proceeded with the usual information to mum and dad around the treatment plan, how to store their medicines, how the device works, and all was going very swimmingly. Then I showed the patient this generic little blue bum bag. Well, that went down like an absolute lead balloon. This delightful 5-year-old girl, not just 5 minutes ago, was now 104 centimetres of fury and threatening to pull out her PICC line with the infuser device attached if she had to put it in that ugly blue bum bag. After 50 minutes of de-escalation, a crying mum, and the promise of a pink bum bag, I can confirm that I now have successful crisis negotiation with 5-year-olds listed on my skill set of my CV. So choice of IV access device is an incredibly important consideration to think about quite early in the referral for paediatric patients. This is because the appropriateness of devices needs to consider quite a few variables. Patient age and cognitive development can impact the success of IV access devices in the home. It's quite incredible how often neonates who developmentally shouldn't even be able to roll are somehow able to end up with central lines migrating away. Infants and toddlers are a particularly difficult cohort as well to manage IV access devices in the home. Their high activity level often results in peripheral cannulas being displaced. Site of insertion can also dictate the treatment success. Peripheral cannulas are generally placed in the cubital fossa, for example, can be prone to kinking on elbow flexion. And we have experienced some cases where continuous infusion devices have effectively been paused overnight because of this. Interventions such as arm boarding and more considered placement of devices can help to reduce this. The chemical properties of the infusate can also dictate the type and site of placement for IV devices. Considerations around the pH and osmolarity generally need to be considered. So the greatest risk for extravasation injury is seen when the solution has a pH less than 5 or greater than 9, or a high osmolarity seen at greater than 600 milliosmoles per litre. Vesicant agents generally should only be infused via a centrally placed IV access device when being given in the home environment. Patient, carers and parents should also be educated and encouraged to undertake more frequent site checks in the home. I guess education being provided on what to look out for potential line migrations, particularly in those paediatric groups who may be non-verbal. Treatment duration as well, generally if you're looking at greater than 7 days, is best facilitated in the home with a centrally placed device. The siting of peripheral cannulas in the home is generally avoided as well due to single staff on home visits, and also the distress potential for this to happen in the home. The intraluminal catheter size is also quite a significant issue in the paediatric in-home service domain. Many of the common elastomeric devices and electronic portable pumps are generally not recommended for use with devices smaller than a 22 gauge. Now, these devices just aren't able to overcome the intraluminal pressures that are seen with such a small catheter. And on audit in our service, we have seen this quite commonly result in suboptimal functionality. For consideration, it's not uncommon for neonates and infants to routinely have a catheter smaller than a 22 gauge inserted. The size of the catheter will also dictate the in-home services ability to take blood draws in the home. Again, for patients with these smaller catheters less than 22 gauge, sampling from these devices are generally not recommended due to the risk of line rupture. So it's evident that the choice of vascular access is quite a highly variable process. So where do we go for the evidence on what's best advice in the paediatric arena? So the Michigan Appropriateness Guide for Intravenous Catheters in Paediatrics, also known as Mini-MAGIC, is the world's first paediatric appropriateness criteria for the choice of intravenous catheters. The study in particular looked at the appropriateness of venous access devices in specialty paediatric populations such as the hematological and oncology groups and in in-home environments. The guidance criteria is also available on a convenient app that you can download onto your smartphone. Now, the plethora of device securement options are also overwhelming out there at the minute. There's dressings, there's glues, there's securement, fancy securement devices. But what's not clear is if one is better than the other. And again, the same team who were running the mini magic, called the Alliance Vascular Access Teaching and Research Group, known as AVATAR, are currently running a couple of interesting trials in this space. The Pharmacist trial aims to improve catheter use in general in cancer patients. This multi-centre study will compare 4 types of different dressings and securement devices, as well as a chlorhexidine sponge versus a plain dressing alone. So the trial hopes to determine effectiveness and cost effectiveness of these treatments during the testing phase. It is expected that the new approaches might be able to halve some of the CLABSIs seen in the population groups and reduce PIC failures by 1/4. The Secure My Intravascular Line Effectively, or the SMILE trial, is also running out of this group, and that's looking at evidence-based securement for peripheral devices. So again, their aims are to assess the effectiveness of more next generation dressings and securement methods, as well as patient acceptability, and explore some adverse event profiles. Now, both of these trials are currently running in both an adult and paediatric setting. So in conclusion, with permission, I just wanted to share a story from one of our long-term on and off families to the paediatric in-home care service. 2-year-old Grayson spent most of 2018 and 19 in and out of hospital following a rare dyskeratosis congenita diagnosis. After 2 bone marrow transplants in 2018, which took over 6 weeks in an isolation room in the hospital, the family wanted to spend as much time as possible at home. The family had already uprooted their lives from Mackay to live in Brisbane for as long as needed for Grayson's treatment, and were trying to get back into a normal routine, as normal as they could manage. HITH gave the opportunity for weekly dressing changes, twice weekly blood tests, and sometimes the administration of IV medications, all done in the comfort of their own home. This also generally meant no lengthy waiting times in the hospital, and Grayson was generally more relaxed in his home environment. And it also helped to have blood tests done the day before appointments so that they didn't have to wait as long. Grayson soon became very accustomed to seeing the familiar faces at home, and it saved him from a lot of anxiety and having to lay in a hospital bed waiting for treatment. He particularly loved the day Nurse Emily gave him a little chocolate gift from her recent overseas holiday. HITH also saved a hospital visit over Christmas Eve in 2018, being able to get some of the weekly cares done in the home as opposed to the hospital environment. In 2020, they're still going strong, and Mum is now trained and in charge of Grayson's cares, which include all of those interventions. But she's comforted by knowing that it's still able to link into the HITH service at any time for any extra support in managing Grayson's day-to-day life at home, and avoid being in the hospital for extended period of times. Thank you, HITH! Exclamation mark, exclamation mark. And that's all from me. I guess we'll open up for questions.
Thanks, Melissa. That's fantastic and good to put, I guess, a clinical face to it. Now, we haven't been flooded with questions in the Q&A, which is unusual. Normally, our attendees normally flood us with questions. The Pisces trial, how long till an outcome from that is expected?
I think they've only recently started that. I think it was early last year. So that, and from memory, it's a 2-year trial. So maybe end of next year.
Excellent. And I think probably the other point you made there is a really salient one as well, that we probably need to think more broadly in the OPAT and HITH space around transitioning to patient and carer self-delivery where it's safe and appropriate. And we probably, in Australia, in the Australian context, sometimes don't put enough context on that. I know it's done in Queensland, not infrequently, but in other jurisdictions, we tend to tie the patient to us. So I think that's a really good point as well. Jason, oh, sorry, yeah, go, Gabrielle.
Oh, I probably should use the chat, but great talk, Melissa. Thanks so much. It's really nice to hear the paediatric perspective. I sneakily downloaded that Mini Magic app that you mentioned mid-talk, and it looks great. Is that something that you use at Queensland Hospital, or and if so, what's your experience with it? Did you have to do a proper implementation process?
Yeah, we have a fantastic vascular access service at our at QCH, and our nurse practitioner is involved in that particular clinical trial, which ran out of Griffith University, and they pretty much extrapolated on the adult study that was done in Michigan, which is called the MAGIC trial, and twisted it for a paediatric focus. They definitely, for a lot of our HITH referrals, will consult around the best choice of vascular access. We definitely try to make it as proactive an approach as possible, just because we find peripheral cannulas in the home for kids is really difficult to manage. So yeah, that's definitely used quite a lot when making referrals and in the early considerations.
Great, thank you.